Hi guys, welcome back. I shall now be discussing aspects related to high altitude pulmonary edema. Definition of high altitude would be height more than 2500 meter. So for people like me who have always lived on the plains, if I take a Indigo flight and land up at Leh and then plan to go trekking right on the first day, I am bound to fall sick. In fact, it has happened that a lot of people who consider themselves to be physically fit and strong, they straight away land up on Leh on the first day itself and they try to do trekking and they fall so sick that they might have to be evacuated by the army. You see, high altitude pulmonary edema takes some time to develop. Usually the manifestations hit you on the second day. High altitude always causes hypoxia, so let's look at some heights here so that we are more comfortable. If we are going to Manali, there is usually not a problem, and you would have been to a hill station like Shimla, Manali, which are usually at the elevation of 2000 meters, so no issues. But once you go up to Rohtang Pass, you definitely gonna be hit by high altitude in a sense that if you stay up at Rohtang Pass for a long duration, that is about 3900 meter, there's a possibility that you will start developing a headache. Why that is so is because the higher you go up, the partial pressure of oxygen will be lesser. Low oxygen will contribute to cerebral vasodilation. That will cause a headache. So if you plan to sleep at a high up tent in Rohtang, you will not be able to sleep properly. You might be having a headache, which you might think is because it's too cold. You might think that it is outside. You are not in the comfort of your bed. That is why you can't sleep. It is not because of that you are not in the comfort of your bed. It is high altitude telling you go back. A lot of people who have tried to spend time at high altitude by the second day or third day might become so sick that I said they might require a proper evacuation. They won't be able to walk, they won't be able to talk. In fact, some of them might even develop high altitude cerebral edema. As a doctor, you might even be giving medical clearance to people who are going for Kailash Mansarovar Yatra in China. That is a height of 6800 meter. Before you give clearance, have a good look at the cardiovascular status of those people, because you send somebody with the congestive heart failure right up at high altitude, he will develop a frank hemoptysis, he will die of heart failure there. And there have been instances when people have literally, forced doctors in the government job to give a certificate because they said, oh, I am a Lord Shiv Bhakt, so I want to go to Kailash Mansarovar, and you give a certificate under pressure, the person dies and the whole family is after you. Kanchenjunga is at 8500 meters. And right up there, Mount Everest is 8800 meters. Well, Mount Everest for ordinary people like you and me will never be attainable because the inspiratory partial pressure of oxygen, the pressure of oxygen at that high altitude is only 43 millimeter of mercury. So maintaining partial pressure of oxygen is not possible, and that is why even those trained mountaineers, when they go up, they carry an oxygen tank on the back, because otherwise at that higher level, survival will definitely not be possible. We are today talking about a disease which is deficiency of oxygen, that is hypobaric hypoxia, which will have two spectrums. On one hand is a milder manifestation called as acute mountain sickness, which will usually be having manifestations akin to a hangover. Like a person went to a party, if you drink too much, you might wake up in the morning feeling groggy. Similarly, the person would be having nausea, vomiting, flatulence, abdominal distension, a general feeling of unwell, and the vomiting episodes can be really a troublesome fact that the person won't be able to eat anything, so dehydration will come up. And because at high altitude you breathe faster, so there is loss of water vapor from the body that can again contribute to the dehydration component. So acute mountain sickness is relatively a milder form of the disease, and acute mountain sickness can ideally be prevented by using acetazolamide. I will explain to you why acetazolamide will usually work in acute mountain sickness, but today our objective is mainly to focus on high altitude pulmonary edema and cerebral edema. To understand the importance of this, I'll put it like this, that our soldiers who are posted at Siachen Glacier, they are the ones who are mainly exposed to high altitude pulmonary edema and cerebral edema. And you see, if a soldier is suddenly airlifted from Chandigarh base to Leh and then he has to go up higher, the problem would be the rapid ascent of the soldier, especially if he is unacclimatized. If he has never been at a high altitude earlier and he is having a sudden acclimatization, and don't be under impression that high altitude pulmonary edema will develop in those who are only unacclimatized, even who have already done a mission at Siachen Glacier. It's the body became temporarily adjusted. They go back to the low at altitude, the adjustment of the body goes away. When they do a re-ascent, again they will also suffer. So two soldiers have been airlifted, they're snipers, they have been airlifted from Chandigarh base going up to Siachen Glacier, if they are gonna go on a specialized mission where they have to target the enemy, especially China, Pakistan, and these snipers, when they go up, there's a possibility rapid ascent might cause them to lose orientation. There have been instances and mishaps at Siachen Glacier where a soldier has shot his own commanding officer, or might shoot himself, or he might start having hallucinations. Why? Because he's having high altitude cerebral edema and the airlifting could not be done. The helicopter could not land to pick up the soldier because the weather was so bad. Blizzard was coming, so helicopter could not land there. So we are having tremendous amount of not only financial spending that government of India is doing in maintaining that post at Siachen Glacier, but the guys who are going up there, they're exposing their lives to something which is a huge hazard. So our objective would be to mainly understand regarding what really happens at high altitude, how the disease will manifest, and while you are listening to this lecture, you are sitting comfortably in the planes at 1 atmospheric pressure, which is about 760 millimeter of mercury. The higher you go up, the PO2 of inspired oxygen will definitely keep on reducing. My objective is to explain to you that why is it that hypobaric hypoxia is so dangerous. Do appreciate the fact that in pathology they teach about hypoxic hypoxia and histotoxic hypoxia or anemic hypoxia. I am teaching you hypobaric hypoxia, which causes two big problems for the patient. One would be that hypoxia will cause cerebral blood vessels to dilate. That's a normal response of hypoxia, all blood vessels will dilate. The dilatation of cerebral blood vessels will now cause stretching of the dura mater, which is the pain sensitive structure in the brain, and that will cause a splitting headache. If you ever been to a high altitude holiday to Leh and Ladakh, you will better appreciate what I'm saying. Though in movies they will show it in a very fancy fashion of going to Leh and Ladakh and then driving a bike, etc. If you ever try to do that by yourself, you will understand the splitting headache that you develop right from the first day does not go away, does not get treated by even painkillers. The second thing that will happen will be, and this is a signal your body is telling you, go back to the planes. Most people are stubborn, they decide to stay back. Now let us see what will happen. The pulmonary blood vessels will begin to constrict. Pulmonary blood vessel is the only blood vessel, that is pulmonary artery, in fact is the only artery carrying carbon dioxide. So pulmonary vessel exhibits opposite behavior to all other blood vessels. This pulmonary blood vessel, when it will constrict, it will increase the pressure in the pulmonary artery and therefore it will result in vasculature. It will cause a hydraulic stress, I would say, on the basement membrane of the blood vessel. So the pulmonary artery hypertension component is so severe that according to the rules of the government of India, and especially Indian Army, and the soldiers who are posted at Siachen Glacier, they usually don't spend more than 6 months there. Why? Because the longer you stay up there, higher incidence of pulmonary artery hypertension can be there, and this person anyway has gone up maybe 1 day ago. The hydraulic stress on the blood vessels can be so much that there could be leakage of fluid from the blood vessels into the alveoli. So capital A means alveoli. This is the pulmonary vasculature, which is relatively constricted in this patient, so the pressure is relatively high. I said this pressure is so high that there will be leakage of fluid between the endothelial cells. It will leak into the alveoli of the patient, and therefore this person will develop a substantial pulmonary edema, which is of the non-cardiogenic variety. If I was saying that person is having heart failure and there is transudation of fluid into the alveoli of the patient, that would be referred as cardiogenic pulmonary edema. This person's cardiovascular system is perfectly normal. Like this is a young doctor, after clearing his exam, he decided to go on an adventure holiday to Leh and Ladakh. When he reaches there, right on the first day, he decided to go out trekking. The guidelines are, first day, don't do any exercise, let your body get acclimatized. By the second day or the third day, go in for hiking or climbing. This chap did not pay attention. Doctors are always short on time. He said, okay, to hell with everything, I'll go up. The higher you go up, even if you're driving a bike, you're not walking, you're not trekking, the higher you go up, the rarefied atmosphere, the hypobaric hypoxia, the hydrostatic pressure in the blood vessel will increase so dramatically that it will overcome the normal integral resistance of the blood vessel. You see, normally fluid does not leak across the blood vessels of yours and mine. But in this patient, the pressure of the pulmonary artery circulation, microcirculation is so high that it will contribute to non-cardiogenic pulmonary edema that will explain the breathlessness in the patient. And in some of these patients, they can even be blood-tinged sputum. They could be hemoptysis developing in the patient. And what should this doctor should do now? Stop the bike and take somebody's help, come back, descent. Treatment of choice for high altitude pulmonary edema is an immediate descent. One more problem that usually develops at high altitude is that when you sleep at that high altitude, because there's deficiency of oxygen, you tend to hyperventilate. When you will hyperventilate, the oxygen levels in the body will tend to increase. So now the body will try to correct it by doing hypoventilation. When the O2 levels will fall, the body will again hyperventilate. Now there is a overcorrection, so body will try to undercorrect, that is hypoventilation. What I'm teaching you is periodic breathing. Most people, when they go to high altitude, are not able to sleep properly. Why? Because they tend to develop periodic breathing. That is, the body is not able to adjust to low oxygen. So first it overcorrects, then it undercorrects. Therefore, the oxygen saturation in the body keeps on fluctuating. This explains the fact that why do you not feel fresh even if you rest properly in a good hotel at high altitude, because your oxygen saturation is not constant, it keeps on fluctuating. This explains the sleep deficit. This explains the fatigue that starts coming usually at the end of the first day. And again, the best way to manage this is ideally that for people who are unacclimatized, like if you as a doctor are planning to go to high altitude to Leh and Ladakh, I would suggest you to take acetazolamide. So let us now study how acetazolamide will take care of at least the periodic breathing component. Acetazolamide is a carbonic anhydrase inhibitor. What it does is it causes urinary loss of bicarbonate. If you lose bicarbonate from the body, then it will cause metabolic acidosis. Acetazolamide induces metabolic acidosis by causing urinary loss of bicarbonate. Metabolic acidosis now causes the lungs to compensate by exhibiting hyperventilation. Remember, in diabetic ketoacidosis, there is small breathing hyperventilation. Same thing happens here. Acetazolamide causes metabolic acidosis in the body and induces hyperventilation. And if you will do hyperventilation, if you take this tablet in advance, if you will do hyperventilation, you will be able to maintain your oxygen levels in the body. If you are able to maintain oxygen levels in the body, the chances of all these complications will be reduced. So do remember the fact that acetazolamide can be used to prevent acute mountain sickness and helps in maintaining oxygen saturation in the body by causing the body to develop hyperventilation. However, acetazolamide has no role in prevention of high altitude pulmonary edema, which is a much more severe manifestation in a sense that now the pulmonary artery pressure is so high that it will cause the blood as well as the fluid to leak into the alveoli and the person might cough out this blood also. Studies by Indian Army have shown that bronchoalveolar lavage in soldiers who have undergone a high altitude pulmonary edema will be having increased amount of RBCs and the protein. That's simply representing that the integrity of the blood vessels is lost. Contrast that with patients of ARDS. In ARDS, you don't have RBCs, you don't have large amount of RBCs, you rather have neutrophils. Just comparing here, bronchoalveolar lavage in acute respiratory distress syndrome will mainly be having neutrophils with increased proteins, again because it is an exudate, but you won't have RBCs present. The protein component would anyway be elevated. The learning from the discussion is that acute mountain sickness is a milder presentation of the disease and the severe presentation is high altitude pulmonary edema. To prevent acute mountain sickness, acetazolamide will make the person breathe relatively better, so it is for prophylaxis. This person that I am talking about has not taken any prophylaxis, plus he is unacclimatized. The guidelines are you should always go slowly. You go particular height like 3000 meter, next day go to 4000 meter, then go to 5000 meter. You should climb gradually. If you climb faster, then the chances of person's body reacting to this hypoxia is substantially slow. What I'm talking about is acclimatization. This particular person that I was describing, like a young doctor who went to Leh or Ladakh after watching a movie and he thought it's a cool thing to do without acclimatization, will fall sick. So unacclimatization is one of the risk factors for development of high altitude pulmonary edema in a patient. We will now see what will happen in a person who decides to stay back. Coming to the clinical features of high altitude pulmonary edema, he will usually describe a young adult. It has been shown that people older than 50 years of age usually tend to adapt better to high altitude pulmonary edema or do not have high altitude pulmonary edema for reasons that are not known. This guy is maybe a first timer. Between day 2 to day 4, he will begin to deteriorate when he will arrive at a height something between 2000 to 2500 meters, which will be approximately 6500 feet. It's unlikely to have high altitude pulmonary edema after the fourth or the fifth day because the body tends to get used to the low oxygen environment. Rapid ascent can obviously increase the chances of this happening, and don't be under impression that only first timers will be having high altitude pulmonary edema. If a person is reclimbing for the second time, like this guy has already been to Leh and Ladakh already, he went on a bike expedition earlier and he's reclimbing again after a couple of years, the severity of the disease can be same or even much more severe, and in fact high altitude pulmonary edema can be lethal, it can be fatal. So what's going to happen in this person? He will first start developing decrease in exercise tolerance. So in trekking, this person will feel very breathless. He will be at the last of the entire team. He might try to catch up with everybody else in the team, which will cause him to start having a non-productive cough. Still, because he wants to show how tough he is, he still decides to continue walking. His body is telling him, stop, go back. He is not stopping because he wants to have, he wants to keep up with everybody. You see, everybody's body reacts different to low altitude. There's no point in showing machoism by saying that, okay, I can walk as fast as the other chap because I think I'm physically strong. So physical fitness has nothing to do with high altitude pulmonary edema. I mean, some people are very physically strong, still they have high altitude pulmonary edema. You see soldiers who can be fitter than them. They go to Ladakh, they tend to fall sick. If they reclimb again, they tend to fall sick. So ordinary people like you and me can fall sick. And if a person is having these manifestations, he should go back. Here I also want to tell you, and I had a doctor colleague who actually took his dad. His dad was a heart disease patient, and I'll shoot a video if possible of that. His dad was a heart disease patient. He took him to Ladakh, and his father died there because his dad was already having cardiopulmonary circulation that is compromised. He was a known case of congestive heart failure secondary to ischemic cardiomyopathy, and they just went on a holiday, just like ordinary people, took a Jet Airways flight, Indigo flight, landed there, and his dad started having blood in the sputum. Because right on the first day, they decided to do some local sightseeing, not that they were doing some adventure sports. So there was a non-productive cough. There is going to be even frank hemoptysis. And even at this point of time, if the person stops climbing and takes medical help, chances are that the person will survive. Otherwise, the person will start developing cyanosis because the fluid is filling up in the lungs, the oxygen saturation will start dropping. There will be an increase in heart rate, increase in the respiratory rate. At high altitude, you would have seen we breathe faster, so we lose water in the form of water vapor. We don't even realize it. We're losing water from the body. So you have to continuously drink water on a regular basis. Not overdo it, but drinking of water is important because otherwise you tend to get dehydrated and you don't even realize that you're dehydrated because the breathing fast will contribute to increase in insensible losses in the patient. The person now, when he sees a medical doctor, he will be having crackles in the chest. Mostly it is middle zone of the lungs which is more severely involved as compared to others. If chest x-ray is performed in these patients, evidence of pulmonary edema is noticed mostly in the left and the right middle zone. There will be no battering edema, there will be no cardiomegaly present in the patient. If ABG is done in the patient, it will show respiratory alkalosis. In fact, that's an MCQ for you. Carbon dioxide washout will occur. If pH is more than 7.7, this person will not survive. Fast evacuation is one that is required. If echocardiography is done in the patient, it will show evidence of right ventricular strain. The right ventricle is trying to work against a constricted pulmonary artery of the patient. So that's definitely a very troublesome fact. And in these patients, that's next is for academic reasons only. Pulmonary capillary wedge pressure is normal. Though you can't measure it at that high altitude, you need a specialized center for that. Pulmonary capillary wedge pressure is normal because this is an example of non-cardiogenic pulmonary edema. The reason for leakage of fluid in the lungs is not that the heart fluid is backing up. It is a non-cardiogenic pulmonary edema developing in this patient, which is due to the increased pressure that gives up the elastic tissue of the blood vessel gives up and the fluid leaks into the alveoli of the patient, which causes increased chances of mortality in these patients. Therefore, we have to act fast to manage this patient. So let us now see what is the treatment that is available for management of high altitude pulmonary edema. So let us now talk about the drug of choice for or best drug for management of high altitude pulmonary edema, and that would be answered as nifedipine. A 60 mg sustained release tablet will immediately cause an increase in the oxygen saturation of the patient because it will immediately dilate the pulmonary artery. Therefore, it will reduce the pressure in the lung circulation, which will reduce the pulmonary edema component also. The next thing which is planned for this patient is an immediate descent. Now, because immediate descent may not be possible due to weather or multiple reasons, enemy gunfire, so we are now having this particular device which I want to show you, and this device is what is called as a Gamo bag. This is made up of nylon and is only 7 kgs and can be carried by the team leader of the hiking expedition. This can be carried easily in a backpack, and this is filled with air with a foot pump. The Gamo bag will provide a simulated descent of about 2000 meters. This has been life-saving in large number of cases. Like at Everest last year, there were large number of deaths occurring because the availability of Gamo bags was limited. Though the Nepal government has done a lot of work in providing base camps at which these Gamo bags are available, but if multiple people will fall sick, the availability of Gamo bags became relatively short. So a lot of those actually climbers, they did not get access to this Gamo bag, and they unfortunately died because inside this bag, just there would be hyperbaric oxygen availability. You can hook it to oxygen tank, it will provide oxygen to the patient. And this is routinely available with Indian Army in case the evacuation is not possible. Otherwise, the high altitude pulmonary edema will deteriorate to even form high altitude cerebral edema. Cerebral edema can cause disorientation. The soldier may actually shoot his commanding officer, himself, or he might just start firing randomly, giving away the position, and the enemy will then shell that position and the entire post is lost. So there have been instances when our soldiers, if you go to RR Hospital Delhi, the Research and Referral Army Hospital Delhi, there might be young soldiers with high altitude cerebral edema who are there in cerebral edema for months altogether. They may never recover. So that's a very bad prognosis that can occur. High altitude cerebral edema can be managed with dexamethasone. We have already explained in CNS component that cerebral edema or vasogenic cerebral edema is best managed with dexamethasone. But at the moment, I have taught you treatment of high altitude pulmonary edema. Do not answer acetazolamide here. It is sublingual or sustained release nifedipine. Whatever is available should be given to the patient along with descent. If not, then a Gamo bag should be used. Supplemental oxygen should be given to the patient. Suppose I'm saying Gamo bag is also not available. At least supplemental oxygen would be available at high altitude. The army sets up a lot of camps, so supplemental oxygen is available. This should be given at standard, 4 to 6 liters per minute. Objective would be to maintain a pulse oximeter value of 90%. And SpO2 value is not a reliable way to understand or diagnose high altitude pulmonary edema. I myself had friends who were showing a SpO2 of 85%, they were fine. I had a person who was having SpO2 95%, he fell sick. So SpO2 is not a very accurate way. Yeah, therapeutically, I want a SpO2 more than 90%. Then in this current edition of Harrison, he has mentioned nebulization with salmeterol. A student of mine, he actually wrote a research article regarding usage of salbutamol with 40% alcohol being given to Indian soldiers who are at high altitude, or they did not have to send those soldiers down because that's a very cumbersome procedure. So salmeterol is currently mentioned in Harrison. The salbutamol with 40% alcohol, actually Lancet rejected that paper due to some technical issues. Indian Army doctors are doing a great job in managing soldiers with high altitude pulmonary edema and cerebral edema. Another drug which is recommended and will treat the pulmonary artery hypertension component of this patient is tadalafil, that is a phosphodiesterase 5 inhibitor. For salmeterol and tadalafil, there are some only case studies which are available. So if they ask you the drug of choice, then the answer for high altitude pulmonary edema is nifedipine in a patient. If a person goes into high altitude cerebral edema, it is dexamethasone which is to be given. At this point, I want to tell you that a lot of these hikers, non-medicos, software engineers who start going to high altitude, they start taking dexamethasone and acetazolamide prophylactically. They think that if they will take it prophylactically, they will not have it. That is not the case. It depends on the management perspective. If you want to prevent mountain sickness, it is acetazolamide. But there is no prevention for high altitude pulmonary edema and cerebral edema. The only prevention is acclimatization. You go up slowly. You don't go up fast. If you gradually go up like 2,500, 3,500 or 4,000, then rest for 2 days, then go up higher. And that's what army chaps do. You see those convoys of Indian Army, they take a long time going up in the mountains because the body will get used to oxygen. They set camps. So ITBP, Army or CRPF, especially when they posted at high altitude areas, they always have a protocol. The doctors there have a protocol of following orders, in a sense that they will stay for a few days at a base camp, then go higher, and if you go up suddenly, then all of this will occur. The drugs that I've taught you are acetazolamide, which is to be remembered for MCQs for prevention. Then is nifedipine, which will reduce the non-cardiogenic pulmonary edema component of the patient, and dexamethasone. So these are 3 tablets which are used for management of a broader term acute mountain sickness, and the severe version of the spectrum is high altitude pulmonary edema and cerebral edema. There have been questions on high altitude pulmonary edema and this time's NEET exam, so I want you to listen to this lecture very carefully. Thank you so much for your patience for listening to me.